peritoneum. Now, I fully understand the peritoneum, the subject, the objective related to peritoneum is not the major objective for this week. I know that because the major objective for this week is the oral cavity, isn't it? Oral cavity, as well as you have the pharynx, esophagus, those kind of things, the upper part of the GI tract, okay? But peritoneum, the objective is so important that without that you cannot understand anything next week. So it's kind of preamble for you. It's kind of very beginning part of your GI tract because many of these structures related to the GI system in the abdomen are involved with the peritoneum. So if you understand peritoneum, you understand almost 70–80% of the organization of all the viscera over there. It's so important. Now, what is the peritoneum? Peritoneum is basically a serous membrane. You know the serous membrane earlier, that it produces a little fluid, not too much, but a little bit of fluid it can be produced, okay? And it prevents the friction sometime, okay? But that's it. Otherwise, the peritoneal cavity is empty, okay? Now, the second part is, it is histologically, it is the simple squamous epithelium. So it can do some diffusion. Simple squamous epithelium, you know, it's a very one layer of epithelial cell. It has two parts. One is called the visceral peritoneum, which is covering the viscera. One is the parietal peritoneum, which is outside, covering the anterior abdominal wall. In order to understand this particular thing, perhaps we have to take you back to embryology a little bit. Okay? I start with this one. A picture, I already made it in front of you. Okay. This picture is well known to you and basically showing you that this is ectoderm.
Yes.
And this is the new ectoderm, means this is the skin, the skin of the ectoderm. This is the neural tube, the neural crest. Remember that?
Yes.
And below that is the mesoderm, and you have the notochord over here. Then is the paraxial mesoderm, intermediate mesoderm, lateral mesoderm, which has two parts. One is the somatic, one is the splanchnic. And below that you have the endoderm. So this picture is well known to you. What I'm doing right now, a little bit one step ahead, I'm making the embryo folding as we look like, all of us look like this way. This is a section, you know, the cross section going from posterior to the anterior. And from posterior to anterior, you can see that the skin is the skin is there, the neural tube is there, and I think, neural crest should be over, like this. Okay, so it's basically the same picture. Then you have the notochord, this. What I have done is just folding it. Remember, embryo folds, okay, from the 4th week onwards, 4, 5, 6, 7, it is basically, folding is almost complete. I'm talking the lateral folding. So therefore, the lateral mesoderm, if it is the somatic mesoderm, it joins with the somatic mesoderm over there. Splanchnic mesoderm joins with the splanchnic mesoderm. Is that clear? So when it is somatic mesoderm over here, obviously the skin is in front. You can see the skin is in front coming from the ectoderm. Then you have the anterior abdominal muscle. Then you have a membrane. That's the membrane I'm referring to. It's called parietal membrane. So parietal membrane, parietal peritoneum is coming from the lateral somatic mesoderm. Is that okay? The visceral one obviously coming from the splanchnic mesoderm over here. In between, you have a space. This space is very important to appreciate. This space is called intraembryonic coelom. Inside the embryo, you have a space. And you will understand in a minute that the importance of this coelom or this space. Okay, it's a tremendous importance for understanding the peritoneum. So let's do one more time. What I'm saying is the intraembryonic coelom is produced because of the folding of the embryo, in which the parietal peritoneum, which is a part of the somatic mesoderm, comes anteriorly, and the visceral one stays posteriorly. But posterior to that, this is also something to observe, that you have the endoderm, right? So endoderm, whatever the structures coming from the endoderm, you know the structures, all of them. It is basically GI system. The esophagus, the stomach, the duodenum, the intestine, the large intestine, all structures, the liver, the gallbladder, the pancreas, all of them are coming from here, remember, not the kidney. Kidney is an abdominal organ, but it is coming from the intermediate mesoderm. Remember genitourinary system? So it is coming from the mesoderm. The other endodermal structure, all the GI tract, you think about it. Esophagus, stomach, duodenum, right? Intestine, large intestine, as well as the liver and the pancreas, gallbladder. So these are the structures. I did not use the word spleen because there is a reason I'm going to teach you next week, not the spleen. So anyway, so it's clear to you that in this diagram, I'm emphasizing a space. The space is called intraembryonic coelom, and it is created because of the folding. Is that absolutely clear to all of you?
Yes.
No question about that? Okay, very good. Now, if I take this membrane out and put it over here, it looks like this. Yes or no? The whole thing, I'm taking it out. That means this is the visceral peritoneum and this is the parietal peritoneum. Behind that, you have this structure which is called the endoderm. Understand this one. Is it clear to you? So what I'm saying, after the folding, you have the parietal peritoneum outside, visceral peritoneum backside, and then behind that, you have the endoderm. If I take this out, it is basically, if I put a little bit of air inside, it becomes a balloon. Balloon, where the endoderm at the backside, and then you have the parietal peritoneum. You can see the umbilicus, nice umbilicus over here. This is the lateral view. Okay, there is the lateral view, so you can understand. Okay, and there's a full balloon over there. Okay, so all the structures I told you, liver, stomach, intestine, duodenum, pancreas, kidney, they are coming from backside. They're coming from the back. Okay, so some structures, they want to go inside the balloon. We call intraperitoneal structure. And some structures, they are very lazy. They don't want to move, like duodenum, pancreas, and the kidney. They will be retroperitoneal. They stay behind. So some of the structures go inside the balloon. Some of the structures, they don't go below the balloon, inside the balloon. Okay? So you need a diagram for me to appreciate this simple fact. So I'm drawing over here. So what I'm doing is, basically the same thing I'm doing it, but I'm giving you a little concept over there that what does it mean, the intraperitoneal structure. So here is the structures which are going inside, like liver, stomach, intestine. The structures we do not want to move, they are like duodenum, pancreas, and the kidney. This is the same one I'm doing like this way. The one which has gone inside we call intraperitoneal. The structures which stay outside called retroperitoneal. Remember, in this one, this is anterior, this is the posterior. The structures are coming from backside. So you need the space. So remember what I said. Very soon you'll appreciate why do we need intraembryonic coelom to accommodate the viscera which want to come inside. Remember, they did not puncture. They did not puncture the balloon. They just came with the two-fold of peritoneum. That's called mesentery. So mesentery, you'll hear more often a term, people use it for peritoneum, is a two-fold of peritoneum attached to a viscera. And this is the two-fold over here. You got it? So when the organ is going inside the balloon, they take the two-fold, one fold from the top, one from the below, they go inside, just like my diagram, and that's called mesentery. So remember, intraperitoneal structures inside the abdomen, every organ will have a mesentery. Yes or no? Because they want to go inside. Yes? Yeah? Oh. Which one? Mesentery is the two-fold of peritoneum. Yeah, this one. Two-fold. One or two? This is two. Yes.
Do we have any organ inside the cavity?
Mm-hmm.
Do we have any organ inside the cavity?
No, inside the cavity there's nothing. Absolutely clean. Nothing is there. Nothing. Empty. Like our abdomen, there's nothing. Think about yourself. Think about. We all have the same thing. You and I look like this. Trust me. There's nothing there. Nothing there. Now why, because this is coming, this is kind of international problem. Why we need this space over there? we need the space because sometimes instead of one chicken, you will have to have 10 chickens. So the chicken will go where? So you have a space. This stomach has a space to expand. Yes or no? Sometimes you don't feel like going to the toilet for 10 days. We call it constipation. But where does material going? So the colon and other the intestine can expand over there. You may say, well, what happens to the kidney? I drink too much of water, but why the kidney is not going inside? No. The kidney has a bladder. Kidney remains the same, but the bladder which accumulates the fluid below down. Okay? So there is a reason for that why the space is important to you. Yes.
When you say intestine, you mean both small and large?
Yeah, both large. The large one has a little problem. Initially it is intraperitoneal, okay? Then at the end, because then it becomes retroperitoneal, a little bit of those. But it starts with embryologically, it starts with the interperitoneal. But later it is retroperitoneal. Because when it is attached to the, like it starts with this, then it falls down to the posterior abdominal wall, so the backside peritoneum goes away. So it looks like retroperitoneal, but in reality it is intraperitoneal, but later it is a colon. You are right, colon is a retroperitoneal later, yeah.
But you said that the duodenum is outside.
Yeah, I'm coming. Duodenum has to be outside, and you'll understand. This is a very beautiful thing. It's coming to you, So in other words, so he said why duodenum should be outside, and it is outside. So it is a retroperitoneal guarantee, okay? So now, what I'm trying to emphasize over here, so say you have the anterior abdominal wall, this is the anterior abdominal wall. You want to do a surgery over here. So what you do, you cut the skin. So remember the skin is over here. The skin is over here. And then you have the anterior abdominal muscles in between. So here is the muscles. These are all coming from the lateral mesoderm except the skin. Agree with me? Okay, when you cut it, you put your hand over here. That is called the greater sac. Greater sac. I'm coming to that. And when we call greater sac, there must be a lesser sac. So in order to understand this detailing of the peritoneal reflection, you need another diagram over there. I'm coming to that. In other words, what I'm trying to do, say, this is the balloon. Organs are over here, but this one is a little complicated, okay? I'm going to draw the complication over here. This is a simplistic view. This is needed for you, how the organs are going inside. But this is not the 100% picture, how we look like, okay? I'm going to draw $1 million diagram. It is, in fact. And I'm not kidding. And you'll see that, how I place the organ in a very systematic way. And the drawing will be absolutely important to you. But this is a concept only. But the complication, I'm going to draw that now, okay? Is that clear? And it's not that complicated. It's very simple. Okay. 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 Say this is the liver, this is stomach, this is transverse colon, stomach, liver, and I put intestine is quite a bit, so I put 2 times intestine. Now look at how I reflect the peritoneum or the peritoneal reflection. It is based on certain system, okay? And this peritoneal reflection, what I'm trying to do, this part, which is basically the visceral peritoneum, it is covering the liver and making 2 fold of peritoneum. So it is a mesentery we call lesser omentum.
Yes.
And then it is covering the stomach and going down. It is called the greater omentum, and it is actually the 4-fold. You can see the 4-fold.
Does not fully wrap the.
And I'm coming. And then it is making a little fold with the transverse mesocolon. And then it is joining over here, and the other one is joined like this way. It is all mesentery over here. So 2-fold of peritoneum, then over here 2-fold of peritoneum, and then here is the umbilical, so you can understand the picture over here. So what I have done over here, very simplistic view, that how this one is properly organized. You and I, everybody has this organization. This is absolutely clear, should be absolutely clear to you. Which means that from the liver, the peritoneum is deflected. It is covering the whole liver except this part. This diagram is important. This is called bare area, B-A-R-E, bare area of the liver. And when you see the liver, when you put the liver in your hand, you'll find that there is a space where there is no peritoneum. It's called bare area. But basically it's covering the whole area, surfaces of the liver. It comes to the stomach. So this one we call is the lesser momentum. Is that clear to you? What is the lesser omentum? Lesser omentum is a two-fold of visceral peritoneum, which is actually coming from the liver to the stomach. That's all. And this is called greater omentum. Greater omentum. What is greater omentum? It is basically four-fold of peritoneum. 1, 2, 3, 4, four-fold of peritoneum. And it is coming from the stomach back to transverse colon. Now, all of you at this stage must remember, underline 10 times in your brain, that transverse colon is a structure which is present just below the stomach. Remember, below the stomach, transverse colon. So, when you open the abdomen, you know where the transverse colon is there. Transverse colon is a part of the large intestine. Large intestine has ascending colon, transverse colon, descending colon. I'm talking about the transverse colon, which is present just below the stomach. And it is connected with the greater omentum. So you can see my diagram, it is connected with the greater omentum. So transverse colon is present below the stomach. Even if I say 10 times, students will do mistake in the exam. So transverse colon, where is the transverse colon? Below the stomach. Transverse colon? Very good. So remember this simple fact. Now by doing this organization, this complexity over here, I make the interperitoneal cavity, which is basically intraembryonic coelom, into two spaces. The space I'm referring to over here is called the, remember I said greater sac? I used the term just a few minutes back. This is the greater sac. This is called also greater sac. Sac means space. So when you remove in the surgery, when you remove the anterior abdominal wall, skin, anterior abdominal wall, and the parietal peritoneum, you come directly into the greater sac. And then you can see the structures. Liver you can see it, stomach you can see it, transverse colon you can see, and intestine you can see it. You should not see duodenum, pancreas, and the kidney. Duodenum, pancreas, and the kidney, because they are retroperitoneal. So you cannot see very easily. You got it? So if this is greater sac, so this is called lesser sac also. So this space is called lesser sac. Or often it is called omental bursa. Omental bursa. Omental bursa. So omental bursa or the lesser sac is a space behind the stomach, and this lesser sac is connected to the greater sac through this space, only this space. So this is connected to this through an omental foramen, often called omental foramen. Omental foramen is present on the lesser omentum. Okay? And it's connecting between the lesser sac and the greater sac. Omental, sometimes in the book, old book will write epiploic foramen in the bracket. It is the older terminology. In the new terminology, you should use omental foramen. What is omental foramen? It is a foramen. You will see all of you actually put your finger over there. When you open the abdomen, you see put the finger over there. Omental foramen, it goes into the lesser sac, from the greater sac to the lesser sac. Okay? And why it is important, I'm coming to that later. So let me go back and orient you a little bit before I show you in the model everything over there. Okay? So, one more time. What I started by saying is that the peritoneum is your learning objective over here because of the fact that you will be experiencing many terminologies in the abdomen next week that is related to the peritoneum or may not be related to the peritoneum. But organization is based on a little bit of embryology. And therefore you start by looking at this old one, which is ectoderm, mesoderm, endoderm. Make sure you're clear. the concept, then you remember the lateral mesoderm has two parts, the somatic and the splanchnic, and you join together when the embryo is folding, creating a space which is called the intraembryonic coelom. And also appreciate the fact that the intraembryonic coelom, anteriorly you have the parietal peritoneum, posteriorly you have the visceral peritoneum. Posterior to the visceral peritoneum, all the organs of the GI system is coming from the endoderm. My picture is showing that. And some of the organs, they want to go inside, which is creating an intraperitoneal structure like the stomach, liver, intestine. And some of the structures, they stay behind, which is called retroperitoneal structures, which do not move, like duodenum, pancreas, kidney. Then, in order to have better understanding of how it is organized, you need this diagram. This is the permanent. You and I, everybody has this kind of structures present. An organization is like this, which means that these are all visceral peritoneum is organized in such a way that it is covering the liver, then it is coming to the stomach as lesser omentum, then it's covering the stomach and goes down as greater omentum, then it's going back to the transverse colon because that structure is below the stomach, so when it's going back, it will hit transverse colon, creating what is called the greater omentum, and then it is transverse mesocolon. This is the transverse mesocolon, the little peritoneum. Again, it is a mesentery. Remember, it is a mesentery. Mesentery is the twofold. There is a special name. So if it's a lesser omentum, is it a mesentery? Yes, it's a special name. Special name because it's coming from the liver to the stomach. Greater omentum, is it a mesentery? Yes. Okay? Special name. The real mesentery, when it is called, which is attached to the intestine, we call the mesentery because there is no special name for that. It is a mesentery, but it's attached to the intestine. So anything attached to the intestine, we call the mesentery. Real mesentery, which is a huge, the mesentery. So this is the mesentery. Otherwise, the transverse mesocolon is a mesentery. Greater omentum is a mesentery. Lesser omentum is a mesentery. So now, the peritoneal cavity, now you can see the other way of definition is, if I ask you to write short note, you'll start writing like this way. Peritoneum is is bounded by anteriorly by the parietal peritoneum, posterior visceral peritoneum. It is a serous membrane, and histologically it is a simple squamous epithelium, so it can participate in the diffusion a little bit. And it has a space inside we call peritoneal cavity between these two membranes. And this cavity is further divided into two parts, greater sac and lesser sac. You got it? Greater sac and the lesser sac. And it's connected between these two is by the epiploic foramen or omental foramen. Now, why we will be learning this thing? Why it is important? It is important for a simple reason. Many times there could be fluid accumulated inside the abdomen. You and I do not have any fluid inside. It's completely empty. Completely empty. But in situations like accident, car accident, okay, something happened over there, a lot of blood is going inside the abdomen. Where it will be accumulating? It will be accumulating over here. Yes, greater sac. And also many times, like when some disease like liver cirrhosis, where the protein level is going down, then the oncotic pressure is low, the fluid will be coming from the blood vessels to the intercellular space. Remember? The opposite direction. You understand oncotic pressure? 27 millimeter of mercury? Oh, you forgot it. How you forgot it? You have done the fluid, the hydrostatic pressure, oncotic pressure, the pressure which takes the, yes? So oncotic pressure actually is keeping the intercellular space dry because it's dragging the fluid towards the blood vessel. But if the protein level goes down, then what will happen? The oncotic pressure is down, so the pressure is going, take the fluid out of the blood vessel. So therefore, there could be accumulation of fluid over there. But whatever the reason it may be, you have to clean it. You open the abdomen and you can clean it, or put a syringe over there and you can draw the fluid out. But while you are doing, actually the fluid cannot be taken out completely from the lesser sac. It's very difficult. It's very difficult to clean the lesser sac because of its position. It is posterior to the stomach and it's very small space. Is that okay? So what I'm saying that when the fluid accumulates, mostly the fluid stays inside the greater sac. But I'm giving importance to the lesser sac because you cannot clean very well the lesser sac. Because if you want to clean it, you have to put a little suction pump, over here, but it's very difficult to clean it. In order to clean, what surgeons do, they cut. Look at this, my diagram. This is a good diagram. And when I'm cutting the I'm cutting the transverse mesocolon. When you cut the transverse mesocolon, look at this, what is happening. All the fluid now is trickling down to the greater sac. Yes or no? Everything is falling over. Now you can clean it very nicely. Absolutely no problem. So what this surgery, you will be doing it routinely. If you want to clean following a surgery, you always cut the transverse mesocolon. There will be no problem. Transverse mesocolon is just the membrane you are cutting. But all the fluid, if it is at all accumulated inside the lesser sac, will be trickled down to the greater sac, and then you can clean it. That's what people do it. So peritoneal reflection is very important for you to understand two things. One, the organization of the membrane or the mesentery, and second, the organization of the viscera. Again, the concept comes with the fact that transverse colon is below the stomach. Is that okay? This peritoneum is important to you because so if there is an infection, we call peritonitis, inflammation of the peritoneum. And it is a life-threatening thing because all the peritoneum are interconnected and it can affect the organ. You can see the liver, stomach, transverse colon, intestine could be all into a problem if there is an infection somewhere. It should be absolutely clean. Peritonitis is a disease very difficult to control because it spreads everywhere quickly. So you have to be very careful that no infection is there. And in order to prevent that infection, you have this greater omentum. Greater omentum is also called the policeman. It contains a lot of lymphatic system, blood vessels, which take care of the infection. We are not getting peritonitis every day. A little bit of infection, it can be taken care of by the greater omentum. That's called the policeman. But if it is a problem, then it's can I get that model over there? Then you'll appreciate now more what I am trying to emphasize over here. Is the anterior abdominal wall has been removed. When you remove the anterior abdominal wall, actually we are removing also the parietal peritoneum. So parietal peritoneum is not there. Now my hand is over here. Where I am right now? Greater sac. Not anterior abdominal wall. Is removed, I said. So where I am now? Greater sac. So I am over here. I'm over here, greater sac. So what I'll be experiencing first is the greater omentum. Actually, you can see the greater omentum. It is a half cut over here, other half over here. And what are the organs? You can see it over here very easily. You can see the liver, you can see the stomach, you can see the transverse colon and intestine. Look at my diagram over here. Liver, stomach, transverse colon and intestine. I put intestine 2 times because if in the section, if you cut the one over here maybe, which is large. Am I correct over there?
Yes.
So one more time. Liver, stomach,
transverse.
transverse colon. So this is the obvious thing you can operate on right away. It's easy. If there is a stomach surgery, it's not that difficult to do it. But if you want to do the pancreatic surgery or surgery with the duodenum or the kidney, you have to remove this thing. So that's why people do kidney surgery from behind. You learn that, nobody does that because kidney is this side.
Yeah.
You should not do over there. Okay? Duodenum you can because you have to pull the stomach, the duodenum come automatically. So there was a question that where is the duodenum actually? So can you remove this? See that the duodenum is posteriorly, is gone backside. Yeah, the problem, international problem is because we create you a problem. Like, we draw the stomach like this way, and then we do the duodenum and the same plane. Actually, duodenum is that side.
Yeah.
You understand it? Duodenum is that side. Duodenum is not straight. So that's what you see over here. What you see over here, they are all intraperitoneal because they came to the intracelular space. You got it now?
Yes.
It's easy for you to understand. So what are the important intraperitoneal structures? Okay, give it that back over there. So you can see the liver over here. So one is the liver, okay? And then you have the stomach, you have the transverse colon, you have the intestine. The duodenum is not from here, it is the retroperitoneal. So if I remove this, you will see the pancreas is coming. So pancreas, if I remove the completely, you will see also the kidney is coming. They are retroperitoneal. So this concept is absolutely important. What is the greater omentum? What is the lesser omentum? What is the greater sac? What is the lesser sac? What is the transverse mesocolon? How the peritoneal cavity or the intercoelomic cavity is divided into two spaces, greater sac, lesser sac. Or sometime in your book, this is more theoretical, which is coming up. I think Dr. Ahmed will explain to you that sometimes the peritoneal cavity could be supracolic, or above the transverse mesocolon, supracolic, infracolic. This is also another division people do it. Supracolic, infracolic. That's all you have to know. This is all objectives I cover.